good evening or good day, good morning, depending on where you are. Welcome to today's ESTS webinar. I'm honored to have today Nuria Novoa, our Director of Education and President-elect here. And she's going to give a talk about in which areas do we need gender-based research and treatment in thoracic surgery. There are several fields where this is already a topic heavily discussed, and there is a lot of evidence in thoracic surgery. Let's have a look what Nuria will tell us today, whether we have sufficient evidence or whether there's areas where we need more. And I'm really looking forward to that presentation on an important topic.
Thank you very much, Clemens. I will start sharing. Okay, I think you can see my screen?
Yes.
Yes, perfectly. Okay, thank you. Good evening, everybody. Really today we are going to discuss, let's say, a hot topic because all the changes that we have seen in the society and everywhere around gender-based differences. And despite this is now a hot topic, it used to be. So you are going to see that there's been a lot of research since even the 1990s, in which there were people that found that there were differences between how we were acting, the differences between males and females. I have no relevant financial discussions about this current presentation. 1 second, I need to do something. Okay. There is a growing body of evidence that is supporting that females suffer, let's say, a different tumor disease compared to males. Therefore, further research is needed for better understanding. This is the main idea. Despite this, we will see that there are no, there are different areas and things are not so, I think, are not so easy. But those are the contents in which I'm gonna base what I already mentioned, the idea that I want to share. So when we discuss if lung cancer, the first idea that we have is lung cancer a male disease. Well, if for all surgeons as I am, I saw that there was a clear evolution in the patients. At the very beginning of my career, I remember to have my, the ward absolutely 99% full of males that were admitted. Well, there was one female once in a while. There was like a surprise, but nowadays this is not the situation. So, looking at the current incidence, what we see is that again, lung cancer is the second more frequent cancer in males, accounting for most of the mortality related to cancer in general. In females, it is also happening the same. It's the second more frequent lung cancer after breast cancer. But as you can see in the slide, it accounts for almost the same amount of mortality, despite being 3 times less frequent than in females. When we look at the lung cancer, let's say more stratified way now with more granularity, what we see is that in most countries around Europe, there is a big difference in the incidence between males and females, as you can see. But I have highlighted the data in North America, northern part of Europe, and also in Australia and New Zealand. Because as you can see, there are, differences at more lower between those areas. When what we have seen can be also seen in these graphs, in which we see that there is a steep and a deeper decrease in lung cancer in patients along the study period, which is between 2001 and 2019 in the United States. But as if you look at the females in the bottom, in the left line, the left graph, in the bottom line, you see that there are not such a big differences between male as in males. There has been a decline, but not so deep and not so steep that it happened in males. This is also related, as you can think, because normally females tend to smoke less than males, and also because they tend to start smoking later, so they need more years to develop the same, let's say, risk situation as in males. But if you look to the male rate, and the proportion is now clearly in favor of males, and because you see that the line is just below 1. When we look at the population, at the younger population, what is happening up to 55 years of age, you see that there is something different. Here, we see the same line that we saw for males, that is happening here, but instead, females are not decreasing so steep, but even they are having more lung cancer, more risk than what is happening in males. And this makes that the female to male ratio, they are much higher, and this is clearly above 1. When we look at the incidence in the global data worldwide, at these ages between 20 and 59 years of age, what you can see is again that in most Europe, the differences between the incidences in males and in females is quite far away. However, both in northern part of Europe and in Australia and New Zealand, and they have almost a similar rate, which is even in an inverse way when we look at the data at North America. So somehow we can say that despite being more frequent in males than in females, the incidence is becoming similar, especially in younger population nowadays, something that was not before. And this is not what I experienced when I started my working in thoracic surgery. So is everything just related to smoking exposure? Does it affect to females as it affects males? This is something that comes next when you think about lung cancer. So as you know, lung cancer is a multifactorial disease. And among all these risk factors, of course, cigarette smoking is the most prevalent, the most important of all. So no matter if we are looking at females or women or males, the predominant cause of lung cancer in everybody is active cigarette smoking. This is something that we need to keep in mind. But there was a time in which there were some doubts or there was some controversy about if tobacco was affecting males and females in the same way, and was producing the same risk for lung cancer. And what we found is that at initial in this study, but it wasn't like in many other studies, it seems to be clear that there was a big difference between males and females, but it was not true. It was not true because really what we had at the time is that in most of those studies, most of those series, they were not comparing or taking into account a series of smoking habits that really influence the outcomes. So, for instance, when this group of people that found, the authors, that found that they were such a big, because they found that the male patients, they have 4 times more risk than the female patients. What they found when they adjust for duration of smoking, average of daily consumption, and cumulative consumption of past years or cumulative tobacco index, what they found is that the difference just disappeared. So somehow smoking was affecting both sexes in the same way. And it was clear when you control for those smoking variables. The problem is that they found a quite interesting point, is that females tend to recover slower after stopping smoking than males. And this is something that we are going to see that appears also in the different graphs that we are going to see around. Somehow we can say that active smoking is the leader cause of lung cancer in both sexes. There is no doubt about that. But what it seems to be different is that once we stop smoking, females need more time, more years to reduce their risk compared to men, which is quite an interesting fact. So tobacco, genetics, molecular, what is this about? What are the new things about this? As you know, the tobacco is influencing either if you smoke it actively or if you are a passive smoke, it produces a series of genomic changes that in the end tend to apply to the KRAS pathways. This is really the key point. So when we analyze these molecular changes and the different genetic factors, what we can see is quite an interesting idea. Here, when we look at these KRAS mutations, we see that there is almost a linear increment of mutations when we increment the amount of back years of smoking. As you can see here in this figure, there is a difference, a clear difference for those that are smoking less or more than 15 packs a year, which is, let's say that is the threshold to say that we have a high-risk patient. But when we look at the never smoking patients, we see, and we look at the EDRF mutations, what we see is just exactly the opposite, which means that when you have a never smoker, and most of those never smokers are females, as we are going to see later on, they will find a lot of EGFR mutations that will almost disappear as long as you increase the number of packs dealers. So this somehow there is a situation in which you are compensating one thing with the other. But when you look at the KRAS, a smoking population, even there, females, they tend to have in some of those different mutations that we can see, for instance, this G12C, for instance, is more prevalent in females than in males, despite that both are popular. There are a population that are heavily smokers. So even also when we are looking at the mutations that appear in never smokers or in very low tobacco index population, what we see is that there are two different types of mutations. One is the typical, the classical, or not classical, exon 19 deletion against the other one. So there are more things going on just behind what we can see. So in the end, when you look and you have a global idea of what are all those molecular and genetic factors that are influencing the development of lung cancer, either in males or in females, or let's say better, in never smokers against smokers, what you can see is that in never smokers, there is a much more is a higher number of DNA abductions, as you can see. So higher number of abductions of DNA, despite there are more smoking conditions, especially in females, that they have. There are more never smokers, and they show a lot of EGFR mutations, and especially exon 19 deletion, which is more frequent in that population of younger patients that we already saw that they were in the previous graph, that they were developing much more number of lung cancer, even over the number of lung cancer that were developed in males. So when we look again, we go back to this study about the lung cancer incidence in United States from 2001 to 2019, what we clearly see that there is a decline in numbers both in males and females for small cell lung cancer, for squamous cell lung cancer, but look at what is happening in the adenocarcinoma. As we see in 2019, there were less males with adenocarcinoma than at the beginning of the series. But when we end this series in the female group, you see that after this huge peak that we have in 2015 or around this time, there is a decline, but the decline is not fast enough. Maybe because we are, females are going behind males, and still there are even more females with lung cancer with adenocarcinoma than there were at the beginning of in 2001, at the beginning of the series. So probably there is something else that is influencing this evolution. So, of course, let's look at what is happening in this gross number of patients that were never smokers. There are a series of factors that are influencing what is happening. Of course, it is clear that there is a larger number of lung cancer in females, never smokers, compared to males. This was clearly established by Wakili and co-workers in 2007. But after that, there were a lot of analysis in worldwide, and we can say that approximately 15% of males will develop, 50% of lung cancer developed in males were in never smokers, against 52% in females. And it is estimated that this kind of lung cancer will appear in 1 out of 4 of all lung cancer appearing worldwide, which is a lot. This is a huge amount of lung cancer. So as I mentioned at the beginning, lung cancer is a multifactorial disease, and among this, there are several factors that probably will have a higher incidence in females, marking part of these differences that we are seeing between groups. The first of it is the environmental tobacco smoke. This was firstly analyzed in children because there was a clear relationship between what parents were smoking and the development of different like asthma, different respiratory procedures in children, but in females, not in females, but in never smokers. It was also very nicely demonstrated in this paper that there was a significant linear correlation between the quantity and the duration of this exposure and the development of lung cancer. So there are some groups of, especially of pulmonologists, that are somehow claiming to include this environmental exposure into the, let's say, the smoking history of the patient, to take it into account when thinking about the possibility of including those patients for screening. There are another issue, another factors that are influencing lung cancer in never smokers. One of them is random. As you know, random is the decay of uranium-238, and is the most important source of natural radiation in humans. It is linked to a certain amount of lung cancer, and and it can influence the appearance of lung cancer not only in never smokers, in which it is estimated that can cause around 1 out of 4 again lung cancer worldwide, but it also influences patients that had a smoking history, even active or passive. So this is a quite important issue because random can cause DNA damage at all levels and can create a lot of tumor instability. And so it can also not only develop the cancer itself, but also influence how this cellular these lines of cells can evolve in the future, even after treatment. So this is something that is quite interesting and should, and of course, it deserves an investigation. So when we are talking about those factors that can be more prevalent among female patients, we need to talk about indoor random. Probably, you know that it is so important that even, for instance, in Europe, I mean, all countries, they know exactly the differences depending on the geographical area. They know exactly the amount of random that they have in these areas of their countries. And in Europe, there is a specific regulation in order to build how to build houses in these areas in which there have a very high levels of random, because they cannot be built in let's say in an equal fashion, and in those areas in which there are no random, or they are in very slow proportion, because it makes a problem when you have an indoor random in a high in a high area, in a high concentration area. You can have even around 3 more times a random concentration in those houses than in normal houses. So in areas in which there is no random in the soil. But also for females, there is well-recognized factors like vapors from cooking oil, and also smoke from burning coal, not only for cooking, but also for heating houses, which is a situation that somehow has a balance with those male patients that go out and work, for instance, in mines, because miners, they have also, especially when miners are in these high random areas, they have a high exposure, and of course, they have a higher risk. So this is something to take into account. But of course, if we are talking about never smokers, we need to take into account hormonal factors. So it's been already proven that their estrogen promotes growth of lung cancer cells. It has been proved either in vitro, but also it has been proved in several clinical series, although there is some debate about that. It is clear that in most non-small cell lung cancer cellular lines, alpha and beta receptors for estrogen are expressed, and those, especially the alpha receptor, are expressed in higher proportion in female non-small cell lung cancer patients. But despite this seems to be quite clear, and well, to have a direct connection and cause and consequence connection between receptors and having this estrogen reception and having and developing lung cancer, this is not totally true, because, for instance, in this important series, it was clear that women, never smokers, that receive replacement therapy with estrogen and progestin, they seems to have an increased risk, with a risk ratio around 1.36. However, it was not totally confirmed, because in this and other 3 series, you can find examples in which there are some series in which even females were not having more risk, that on the contrary, they were having less risk, and others in which there was no risk at all. and all of them were large series of cases. So it is surprising what the findings were. And like this is not totally confirmed, I think this is a quite interesting line of future research. And it will be a very interesting, I mean, whatever it results, it will be very important, especially for those women that need to have somehow this replacement therapy for diverse other diseases. So, and following with this hormonal situation, there is a specific and very specific group of female patients that are those that have a previous breast cancer. And in several series, it was developed that approximately, it was found that approximately 10 years after suffering an initial breast cancer, around 10% of these females will have a second malignancy. And when looking at those malignancies, at those second malignancies, most of them were lung cancer. This was very nicely presented and analyzed by this series from the Memorial Sloan Kettering Cancer Center, in which they compared these two cohorts, patients with just one primary lung cancer with those that has this primary lung cancer after having a prior breast cancer. And what they found is that those patients that has a primary lung cancer after the breast cancer, they were older at diagnosis. Remember, normally they were discovered like 10 years after the initial cancer. They were diagnosed in an early stage, which is normal because they were somehow discovered in their surveillance of this type of the other tumor. But they found no differences in histology, no differences in germ alterations, no mutations. They were nothing different from the global population. But what this was different is that most of them, they were HER2 negative. They have a high, more than 60% have a radiotherapy prior because of the breast cancer prior, also affecting the lung somehow, and they have a larger tobacco index. But despite that, they seem to have exactly the same overall survival, the same evolution, and in those cases in which they have no prior breast cancer. So they were evolving exactly the same. So as we have seen previously, because I already mentioned, and you know from the literature, adenocarcinoma is the winner. And there should be some reason for that. But before knowing that, there were some discrepancies between the series. And as I said before, again, Waki Haley and the co-workers, they were able to do large comparisons between large series of cases of different origins. And as you can see, in never smokers, the proportion, this is one example of a big table in which they presented the results. In never smokers, adenocarcinoma was the most prevalent type of tumor. And this was especially high in females, in which, for instance, in this series, they expressed this type of lung tumor up in the 70% of all this lung cancer. So let's go back again to those graphs that we have seen previously, and as you can see in the global population, we already saw that it was an increase around 2015, and now there is a decline line. But this decline line, it is not going back, not even to the place where we were in 2001. But if we look at this young population, remember that we were talking about these differences, both in incidence and we will see also in mortality, are due to this huge amount of adenocarcinoma. That again, when you look at the female-male ratio, you can see that there is quite high above 1, because we have a large number of females suffering this. So As we have seen until now, there is a significant larger number of adenocarcinoma in never smokers, that most of them are females and especially young. So, okay, we have somehow we have this population already in mind, but do they have a better or do they have a similar outcomes? How does that come now? If we look at the mortality, comparing males and females, well, when we do an analysis by standard rates, we see that, again, in most Europe, we have a huge difference among the mortality in males and females. But if we go, again, to northern parts of Europe or to North America or to Australia and New Zealand, we will see that the figures are not so different, but somehow they are still different. It was interesting to note that back in 1990, there was somebody who already saw this, that there were some differences in presentations and that there were also some differences in survival. This was published, and several years later, the controversy came back, and we saw that there were findings that they were exactly the same as what they found back in the 90s. In this series from a large European cohort of patients, they demonstrated, they confirmed that the females have a better outcome compared to males, either in crude hair ratio than in adjusted hair ratio. But in this other analysis from a large series of cases from North America, you will see that because they did a further analysis in which they adjusted this survival for histology, stage, age, and diagnosis period, and they found again that females had a very global outcome than males. But when they look at the adenocarcinoma and they adjusted the survival for the stage, age, and diagnosis period, again, there was a significant difference among both cohorts in survival. But also, it happened exactly the same when we were looking at localized disease. But it was also in the United States, but it was confirmed once more in a large Japanese series. Again, they found out that the estimated hazard ratio was much favorable for females that when we were talking to males. But it's true. When we think we have never smokers, especially females, most of those patients will be diagnosed having some mutations, some drivers mutations that can confer some survival benefits. And also we can say, okay, we were looking at some series that were analyzed and were done along at the beginning of this century. So maybe data is not exactly the same, but if we, I was meaning, there was analysis in which not other molecular analysis was performed because there was no possibility at that time to do this easily in such a large population, because there was large populations taken from long time before those analyses could even exist. So if we go back again to that time in 2010, again, if in this another Japanese series, they analyze a large series, as you can see there, more than 4,000 males and more than 3,000 female patients. And what they found is that females were doing they were doing better, not only in adenocarcinoma, but also in non-adenocarcinoma. So somehow, although we have this data at that moment, we were not able to analyze in such a huge population driver mutations, the outcomes were exactly the same. So if we come back, if we analyze more recent data, let's look at this interesting paper that was presented by the Finnish group, and that they decide to do this analysis after another study from a national database in Norway. They found out that in general, females have a favorable resection pattern in all stages and all ages, except in patients that were over 80. And probably this is related to the fact that in general, females tend to have less comorbid, or they tend to have a less comorbid, they have a better general situation, they are in better general status, allowing for more surgery and also for, in some cases, when needed, larger extension of resection, making better outcomes on the end. But when you look at the general, at the main data in the paper, what you will see is that female patients not only have a higher resection rates, as you can see in the figure, they have also better survival after resection. On the other hand, this paper also underscores the relevance of surgery in this pathology. So this is something to think about, because even with even we are getting better results when we are able to operate those patients in a complete way. So somehow I can summarize this saying that female shows a favorable resection rates and survival compared to males, both in adenocarcinoma and in non-adenocarcinoma lung cancer. What are the consequences of part of what I've been discussing in this presentation? Some of the consequences are clearly focused on screening programs, and this is quite a serious situation, because we have no at this moment no current screening program will find most of those females never smokers that we've been talking about. So that's why there are some groups, or especially pulmonologists and oncologists, that are trying to force to include previous environmental tobacco exposure in the tobacco screening criteria. Also, they are somehow suggesting to implement screening for those cases, screening for those areas in which we have a high random proportion in the soil, because probably we will detect those patients in an earlier stages. And also there is another group of doctors which are asking to include this long-term survival patients from breast cancer also in specific screening programs, because we know that up to 10% of those patients will develop this lung cancer in the future. So in conclusion, I would say that definitively there are differences among sexes that we need to understand, and opening a broad lines of research at different levels. Probably my conclusion after doing this review is that probably sex could be a surrogate for other factors that we do not know and we do not understand. And we need to understand in order to provide the best possible treatment for this diversity of diseases that we have here. And of course, as I mentioned before, part of these differences mark the profile of patients that are a challenge now, and they should be included in the screening programs, because now they are not anymore. So if I have to answer the question that was posed at the beginning, is there a need for a gender-based research and treatment in thoracic surgery? My answer is definitively yes. Thank you very much for your attention.
Thank you, Nur, for this excellent in-depth overview on gender aspects in lung cancer. So in the screening programs, you were mentioning the survival advantage in women was markedly superior compared to male. This might, of course, also be related to inclusion criteria and numbers included. But are there any other factors why this has been found, and how should this be regarded in future setup of screening programs?
Yeah, probably this benefit was coming from those driver mutations that were there in those females. That there were there's again another issue that I haven't mentioned, but if you look at the literature, also you will see that again it's not in resection, but also there is a benefit in the type of response after using, for instance, TKI or any other specific if it's specific target medication, because this is really unknown. What is the situation? Why it's happening? But this is the situation. This is the fact that the females tend to answer better to this. The response rate is better to this treatment, which is also another interesting issue to analyze. Why is this for? Because we don't know. But of course, there should be something there. Another issue is that in general, I'm talking in general, not for very, all of us, we have very females with very much advanced stages, but even in advanced stages, but in earlier stages is much more, females tend also to survive better, as it was demonstrated by the from this study in Finland, than even the males. So there is something in the bottom, but probably it's not related to if we are females or males. It is relating to something else that we don't know. So that's why we need to absolutely to go further in this research, because there are interesting and important differences among sexes.
I would also like to encourage the audience to ask any questions they come up. So you, of course, due to the sheer number, most data are available in lung cancer. In other tumor types, there are, of course, less data, particularly in tumors where occupational exposure is an issue, like mesothelioma. The incidence is also much higher in males compared to females. So you mentioned that gender might be sort of a surrogate parameter for other factors as well. Can you maybe summarize a little bit in other thoracic tumors what the level of evidence is, whether there are gender aspects relevant, particularly with regard to prognosis and treatment algorithms, probably?
Yeah, no, absolutely. This is absolutely true. I mean, I haven't mentioned because I focus on my cancer, but when we are talking about the mesothelioma, there are two different diseases. Absolutely, it's not only the fact that we have much more mesothelioma in men, but also they have also better survival, and also there are different mutations that are involved in the development of the mesothelioma. But it's also interesting, not only in mesothelioma, also in esophageal cancer. There are differences in evolution, also in survival, and in general, in outcomes and in survival. There are big differences among the males and females. I mentioned that there is a surrogate, but probably sex is a surrogate or something else. The problem is that we don't know exactly what is behind. Maybe it's not because, for instance, for mesothelioma, most of the cases that are also involved, asbestos is there. I mean, it's there even for males and also for females. But it's true that they are not developing the same type of tumor, the same aggressive tumor as it is in male. In general, females, they tend to provide less, to produce less important amount of disease. But despite having even the same risk factors, for instance, in mesothelioma, there are differences in survival, and this is something that is now in quite interesting study, but it's not quite clear. This is not quite clear because again, there are a lot of differences. There are a lot. When you take the series and you look at the results, maybe there are some interesting lines to develop, but then there is a new paper that appears and said, oh no, there is a lot of controversy and this is not happening in my series. So we are still working on that, and probably I don't expect to have to be that we need to wait too long in order to have interesting results, but it will be we need some time to know exactly where are the differences. But again, we need to do this gender-based research, absolutely. But I can tell a specific thing.
Right. If in the field of cardiology, there's also some well-described data that women present with different symptoms for the same disease, like, for example, myocardial infarction. In thoracic surgery, the diseases we're dealing with, I'm not really aware of any good data where that there are gender-related differences in the presentation of symptoms. Are you aware of any data, and is this something that's worth further investigation?
No, really. In my opinion, there is nothing. Or maybe there is something, but it's an anecdote more than a serious study or a big study. And as far as what I've seen, I haven't seen anything. No one has found any specific thing. Probably the only group of patients that could have different symptoms, if any, are those like the breast cancer patients in which they found the lung tumor before even having any type of symptoms, because they were discovered during the surveillance of the breast cancer. No, I don't think there is nothing specific that we can mention or that could be worth mentioning, because no, not until now. But I think again, this is something that we need to analyze, because we don't know. I'm sorry to say.
Yeah, there's just a few diseases where we know that there's actually a gender-based difference in the incidence. For example, if you're thinking of it's not malignant disease, it's benign disease, idiopathic subglottic stenosis. This is something that's more frequently seen in women, and the reason is still not fully clear, even though there are some theories around. But in a lot of cases, probably gender really is a surrogate parameter for exposure to other substances or different lifestyles sometimes.
Yeah, again, we go back to environmental exposures to something that we really don't know, or these type of things. As you mentioned in the subglottic stenosis, these are quite clear. There are several factors, but it's true that females tend to react more aggressively than males to, for instance, reflux that they do they develop this stenotic subglottic situation in which they have a very bad time. Yeah, this is quite interesting area.
Is there a difference in how male and female thoracic surgeons are approaching this topic?
Well, what I can say is that having a female in a team is a quite positive. It's a quite positive thing. I don't think that females and male surgeons we are approaching the problem this problem in a different way. But it's true that females we are approaching our patients in a different way that males do. And probably we do better. We do better because we are not only offering those patients, let's say, the technical based way of doing, but also a more, let's say, human approach that it was not that is not so easy. I don't say that males cannot do it equally well, but normal, this human approach that patients do really appreciate mark a big difference in how we are treating our patients. But it is not really a fact, let's say, from a research point of view, or it's not a fact in from another areas. It's just that is interesting to have a female in a group because they will give you this special touch of humanity that sometimes is not present in more males, but not for research and not for other issues. Well, maybe we are much more concerned about that, but that's all.
Is this something where you think research should be done, or is this something that's well enough investigated?
No, I think it should be investigated too. Yeah, because in this area, I think that everybody can. I mean, there is also females who are not so, let's say, so human to their patients. I mean, this is a fact. So we need to research and to analyze exactly how we are doing, how we are treating our patients, because everybody will learn. Absolutely. So I think we should focus also. I mean, there will be another area of research, interesting area of research, to focus exactly how we can each sex is managing the same disease, how we can approach them, how we can help them. This is very, very interesting, and of course, each one has to learn from the best. That's let's do something like a benchmarking in between people and see what are the results. But I'm really curious about what could be the results of this analysis.
Okay, so if there are no more questions from the audience coming, I think we've come to the end of today's webinars. As always, I'd like to draw your attention also to the next upcoming webinars. There will be one ESTS AstraZeneca sponsored webinar next week on Wednesday, the February 28th, where we will talk about new technologies in lung cancer from diagnosis to surgery. And we have Helmut Brosch presenting on artificial intelligence in lung cancer imaging, and Francesco Guerrera talking about augmented reality during segmentectomy. So more technical approach. And the next educational ESTS webinar will take place on March 11th. And Lawrence Kuhleman will talk about DCD in the field of lung transplantation. So once again, Nuria, thank you very much for an excellent presentation on this topic, and looking forward to see you all soon.
Okay, thank you very much, Clemens. Thank you for the invitation.
Thank you. Bye-bye.
Bye-bye.